Welcome to Focus on Seniors, a television show sponsored by Helping Seniors of Brevard County, Florida. The show is designed to make you aware of senior issues, needs, and resources available to help us age in place and with dignity. This show will help you as you develop your own aging and care plan.
I'm Joe Steckler. Welcome to Focus on Seniors, the television arm of Helping Seniors of Brevard County, a show designed to provide you with information on how to develop your own aging and care plans. Our topic today is rehabilitative care. And with me in the studio is Wendy Willis, who is the community liaison for Wuesthoff Progressive Care Center, and Jenny Gibbons, nurse manager for the short-term rehabilitation for the Wuesthoff Progressive Care Center. And folks, I want you all to pay particular attention to what Wendy and Jenny talk about, because understanding rehabilitative care and the continuum of care, and today we're talking about the continuum of care provided at Wuesthoff Hospital Systems, because they have, we have the whole system, but we've got assisted living, we've got nursing home care, we've got rehabilitative care, we've got home care, we've got home care, we got a service side of it where we have all the gadgets to help people.
Mm-hmm. Medical equipment for the home.
One time I needed a break because I kept hitting my elbow and I had a boil on the elbow. And I finally found the right pad at the Wuesthoff Medical Locker over there on Barton Boulevard.
Mm-hmm.
Okay.
Yep.
Now, this is not a plug. I'm not trying to sell Wuesthoff Hospital System. But I'm using Wuesthoff Hospital System as an excellent example of what a good continuum of care system provides. And that's a fair statement, isn't it?
Yes. Yes, it is.
Most definitely.
I would, listen, as a marketing lady, Wendy, I would expect you to say that. You'd be in trouble if you didn't.
Definitely.
Yeah. You made a statement that, both of you made a statement before we started the show that if you were passionate about your topic, you could speak loud and clear so that people understood you.
Yes.
And I think that's going to happen today because I find that television shows, if the people, the panelists, enjoy what they do, believe in what they do, they can help people trying to gain education and information much better. Mm-hmm. So, what do you do, Wendy, as the marketing person? And you're also a registered nurse, so
Yes.
you have a good understanding of if a person's in pain, if they need. When we get into rehabilitation, it's a whole different area of medicine. Mm-hmm. Mm-hmm. As a marketing manager for the Wuesthoff Rehabilitation Center, what do you do?
I go out into the community and try to make folks aware of the services that we offer, because we can take care of someone from the hospital all the way through till their medical event is over. And I work with our other marketers to bring those things to the community via health fairs and senior fairs, and visiting the hospital to evaluate potential patients for our rehab or our long-term care or our assisted living to see where they are in their functional status, to determine the level of care that they do need. Sometimes they can go straight to assisted living, but sometimes when people come out of the hospital, it is extremely important for them to get that rehab time, for them to, because if you put someone in a bed for a week, their functional status declines, and especially with seniors, it declines pretty rapidly. So even a short stay in the hospital will be an indication for them to come to therapy to regain the strength that they had, because we want them to be at their prior level of functioning. So whatever their functional status was before they became ill is where we want to bring them back to. If they were living in an assisted living facility, it still may be that they need to come to rehab. Town Square, our Wuesthoff's assisted living, we frequently have folks from there that go into the hospital for various reasons that do have to come into Wuesthoff Progressive Care Center to gain their strength before they can go back to the assisted living. And even when they get back to the assisted living, our assisted living building has an outpatient rehab aspect to it, as well as we do have a physician office that is adjacent to the assisted living. So it's a very, very convenient place. We have the lab comes in Monday through Friday for an hour to draw labs. It's very convenient for folks at IRCC to come, and they can drive their golf carts over, they can go to the doctor, they can do their outpatient therapy, they can get their blood drawn. So that facility offers a lot of things. And a lot of our residents there do transition from Wuesthoff Progressive Care Center short-term rehab back into their normal home environment, which is the assisted living facility.
Is there an advantage to having a nursing home section in a place where you have a rehabilitation also? Do you find that you're the nurse, Jenny? You're the nurse also, but you're the nurse there. Do you make the people in the nursing home available of services in the rehabilitative center?
Most certainly. All of our patients and residents have access to the services we have for therapy. If we find a patient that is a resident has declined in their functional abilities, they're not at their optimal, we'll bring them back into rehab with physical therapy or speech therapy or occupational so that they can regain those skills. We bring them back up to either their prior level or the best level that they're able to perform at so that they can still have quality to their lives.
Okay, now, I got ahead of it, but we define what Wendy does, but how about telling our viewers what you do? Because it was a surprise to me that you had a nursing unit. You actually have 2 nursing units.
That's correct.
And your nursing unit does what?
Mine is the patients that are in our facility for short-term rehab. In other words, they come in usually from the hospital. They've had a significant situation that caused them to have to be hospitalized, whether it's a surgical or a cardiovascular, whatever that is. It has brought them into the hospital. And like Wendy said, because we have muscle wasting after we sit in a bed for a period of time and we get weak, we have a need to be able to gain that strength and ability back up. So we bring those patients from the hospital into our facility to get them back at that optimal level. We want to at least bring them back to the level they were prior to going into the hospital, and if at all possible, better than that. Our goal is to get people back home. We want them to be able to go on with their lives and have quality to their life. Sometimes, unfortunately, some people are not able to go back into their homes if they were living by themselves. They may have more needs than what they had prior, and that's why we have other things available like the assisted living.
So if a person came out of the hospital, went into rehab, and you found that if they couldn't go back home, then you have 2 options. You could put them in the town square, which would be the assisted living facility.
Correct.
Or it could put them in your long-term health care. I like to use the word elements of care because in the healthcare system, there is a definite place for each element.
That's correct.
Sometimes we can stay in our homes and send somebody to daycare, and that's adequate. Or we can have your home care people come in, not just skilled nursing care, but you can have CNAs, or you can have somebody who could come in and help with babying, assist with activities of daily living, and do that. But then we have the other elements of care we have as we move up the line. You might have to go to assisted living. You might need rehabilitative care. You do rehabilitative care in the facility as well as home, too. Your home care outfit does rehabilitation in the home. And I've had home rehabilitation. I've never been in a facility for rehabilitation. What do you both think is the major difference between rehabilitation in a center and rehabilitation in a home?
In a home, you are still reliant on either family who may not have the ability to provide 24-hour care if they're having to work or things like that. In a facility, you have that 24-hour care consistent. You have people that can help you in and out of a bathroom. You may need assistance of a person for balance, for ambulation. You may be in a wheelchair because you're non-weight bearing on an extremity because of a surgical procedure or something like that. And we're skilled and able to transfer that person on and off of a toilet, in and out of bed, in and out of the wheelchair. And our facility has assistive devices that will help them, grab bars like in a bathroom, things that may not be in place in a home that will make that a lot easier. Our tables in our dining room are wheelchair accessible, so they're a little bit higher than what your dining room table would be at home. So our environment is more conducive to assistive devices that would be necessary in order to perform their regular activities of daily living, like eating and going to the bathroom, getting dressed, getting showered, things like that. And there's a person or two people that will assist them, whatever their needs are.
Okay, now you're a nurse and you handle the stuff that goes on in that center.
Correct.
And you're a nurse and you handle the marketing on the outside. Mm-hmm. You mentioned the word grab bar. Mm-hmm. Do you, either one of you, as a course of your instruction to clients and their caregivers, do you recommend to them that they have grab bars and things like that placed in their homes when they come out?
What we do is when our patients are getting close to that point that they're ready to go home, not quite there, but close, we will ask if we can come into the home and do a home evaluation.
Okay.
Our physical therapist or our occupational therapist will go into the home and have the patient go through their normal activities like getting in and out of bed, getting in and out of the bathroom, in their kitchen, all those little things that they would normally do, and see how they're able to perform and what their needs may be. If there's either equipment that we need to order for them to be able to use to help them in the home, or is there things like the grab bars and all. So, and it also lets us know if the patient isn't quite at that point of being ready to go home, where we need to focus to get them prepared. And that way we have a week or so still to work with them to get them at that functional level where they can be independent or close to independent at home and have a good discharge home. We don't want to see them back in the facility. As much as we love the people we work with, we don't want them to come back as a patient.
Starting 1 January, if the new law applies to rehabilitative care coming out of a hospital, as it does for if you have an event, you have to go back into the hospital within 30 days, and the hospital has to pay a tax on it. It makes us aware.
Mm-hmm. And it makes us really interested in that aspect, even in our skilled nursing facility, because we are a hospital system. So if we send someone home and they end up back in the hospital, that affects our system. So we really work hard to make sure we have safe discharge. One of the things they look at when they go in the home are there hazards. They want to make sure if they go home with an assistive device, if they go home with a walker, that they are able to get around in their home. They may need to move things around. They may need to build a ramp, or if they have a step up, they may need to put a little incline on that so they don't have to do that large step up. Throw rugs on the floors or trip hazards, they would all need to come up. There are a lot of, little things that we don't really think about that the therapists are trained to look at when they go and they do their assessments of the home. And we have an excellent therapy department. Our therapy department, between our occupational therapists and our rehab therapists, they have about 290 years of combined experience. Everyone compliments us on our rehab staff. They're very caring.
Is that because you have a lot of people, or because you got a lot of old people that have been there a long time doing it? Now, what is it?
No, we have a pretty large staff, but we have a lot of people that are in that middle 20-year.
I know, I'm only kidding.
Yeah, we do. We don't think we have any really old. We have a couple of young ones.
Now, the purpose of this show is to let the viewer learn. Ask a question. Your therapist, when they go into the home and they decide that a person needs grab bars or build a ramp, do you have a service that does that, or who do you recommend to do that?
Our rehab manager actually gets involved. Kelly Lynn is our rehab department manager, and she gets involved with setting up all of the home equipment, assistive devices, and assisting the family in finding the right resources to get those things accomplished in a timely manner so that the patient can go home.
What I was kind of getting at, does she know that, we used to call them Community Services Council, now they're called Aging Matters. Does your section, does it know that Aging Matters has a program that does build ramps for people and does put grab bars in?
My rehab manager, I'm sure she does. She's been doing this for 22 years, so she pretty much knows just about everything there is to know. And
that's a good one.
She is an excellent resource for me because she tells me the places that I can go to talk to people all the time. She's an excellent resource, and I'll have to ask her about that.
Ask her.
I will. I'll have to ask her about that.
But there are things that it's always easy to talk on television about very personal things, but I will. After I came home from my hip surgery, with the extension of the hip and everything, our commode was, say, this high. There are the older commodes that are this high. But you have newer commodes they put in that are this high. Mm-hmm. Aging Matters came out to my house, put a higher commode in, and it actually would have been, all I had to pay for was the actual price of the commode. Mm-hmm. But then you can make a donation to them to help provide the service for somebody that couldn't afford it. Mm-hmm. So we did that. But one of the smartest things I've done in home modification is put what I call the high-rise toilet in because as you get older, your hamstrings, they become tighter, mm-hmm. and it's more difficult to get up and down off of a lower commode.
Mm-hmm. Yeah, your knees can't support that either.
Instead of putting that fixture over there and we can get a mess on that thing, just put a higher toilet in, and you've accomplished a lot of things. But these are things that come up in rehabilitative care, mm-hmm. and it's so important. There's so many ways that we can make life easier. Mm-hmm. What are some of the other things as a marketing manager for rehabilitative care that you do, Wendy, that I haven't asked you?
Well, I communicate a lot with our other services to see how we can integrate those into our facility as well. Hospice can come in and take care of folks on our residential care unit, which is the nursing home aspect of our facility. If someone needs hospice care, they can come into the facility and provide hospice care while they're in our facility, which just sort of enhances and adds to the care we're already providing. They can have social workers come in. They have their own volunteers that can come in. They can spend a little extra time with those patients because at that point in their life, that extra time is extremely important. I was an oncology nurse for years and years, and so
that's what my daughter is.
I had a lot of experience with that end of life process, and it's extremely important. So our social worker is always looking at that, and if someone looks like they can benefit from that service, it is an excellent service, and we in our hospice can come into the facility. They're really awesome. We also, they can come in for our short-term residents as well, but there's a little bit more oversight in that aspect of it. If they fall and they break their hip and they get it fixed, or it's not something that needs to have surgery, but they could benefit for some rehab, even if they're in hospice, say they have end-stage COPD, and they are receiving hospice care for end-stage COPD. Coming to get rehab for a completely different diagnosis will enhance their quality of life. So even if they're on hospice, there are circumstances that allow them to come to short-term rehab, because that's what hospice is for life-limiting illnesses. It's not only for somebody whose death is imminent. If you have end-stage COPD, you know that it's going to limit your lifespan. They have lots of services that they can offer. So we're really glad that we can also have those services within our facility.
We're talking about the overall continuum of care.
Mm-hmm.
Yeah.
Yes.
Let's just talk for a minute, 3 or 4 minutes, about rehabilitative care. We haven't really talked about that. Rehabilitative care is, we mostly think if somebody's had a shoulder replacement, a hip replacement, or a knee replacement. But there's also stroke, heart disease. What do you do in rehabilitative care, Jenny? You're the nurse over there. What do you do?
There's a lot that's done. We work with the different modalities, like I explained before. Let's say somebody might have come in with a stroke. Well, besides physical therapy and occupational therapy, speech would be involved. They may have issues being able to swallow safely without coughing and choking on their food. So they may have started on a thickened type of liquid or a thinner consistency of the food where it's not something that would catch in their throats when they're trying to swallow. Speech is going to give them different exercises and work with different techniques on how to safely swallow. And eventually they'll keep upgrading them until they can go back to a regular diet and thin liquids and be able to go home on those diets. They will help them with cognitive deficits. They will help them with speech problems. Again, a stroke is a good example. Sometimes they have, because of the one side being effective, it will cause them to have a problem with clear speech because of the muscles not being as strong in that side. And they'll help them with that. They'll help them to work on those strengths, do exercises to strengthen those muscles on the other side of the face. And that helps them as well. Our staff and the nursing staff, that is, we're going to follow through on the things that they have taught them and worked with them in the different therapy groups. As far as how to transfer, we'll be continuing that in the room when they're out of therapy. So we're still doing those same principles, how they need to follow through. Let's say you had the hip. You had hip precautions when you had that hip. So we're going to reinforce that. We're going to do a lot of education. That's the big thing about rehab is education. That education is not just in the therapy departments. It's in with the nursing group. We have...
I've been in... outpatient therapy in at least 7 or 8 places. I've done a lot of that. But the one thing I never thought about was the fact that when you have like at the Progressive Care Center, where you have the 54-bed unit for rehabilitation, most of those people still require some nursing service in addition to the therapeutic service.
Correct.
You don't do the therapeutic part of it, or do you?
We continue what they're doing in therapy. If they give us certain things that they need to do as far as, like a good example is a knee, somebody who's had a total knee replacement. They have what is called a CPM. It's a continuous passive motion equipment. Their knee goes into the machine and they're strapped into place to help keep it immobile so that it doesn't cause any problems while they're going through it. And it's going to bend and extend the knee. That's to get their range of the extension and the flexion on the knee from the surgical procedure. And we do that on the nursing unit. That's not done during physical therapy or occupational therapy. And they'll spend a couple hours a day, twice a day, in that machine. And that helps to get, like I said, that extension and that flexion back.
They do. See, that's one of the things you really can't do with home therapy.
You can. What happens is if you have a family member that's in the home, we can educate them on how to use the machine properly.
They bring that machine into the home?
They can.
Yes. Yes, they can. If it's still needed. Generally, it is not needed when they're discharged.
Okay.
It is generally not needed at that time. But it is available in the home, but it's not often that happens.
Say if a person comes, when they come out, if they've had a hip replacement, how long would you expect them to stay in the progressive care center?
A lot can depend on other things that's going on with that patient. Everybody progresses at a different level and a different pace.
I understand. But
they may be in
average.
They may be in, let's say, a week and a half. They may be in 3 weeks. They may be 6 weeks. It depends on other, if they have a major wound, maybe as well as a hip, or they have comorbidities, diabetes, maybe new onset of diabetes, and they're being regulated with their blood sugars and finding the right medications that would manage it the best. So there's a lot of different things that can change that, and healing changes with different problems. COPD, you're not getting as much oxygenation in the cells, so it takes a little bit longer for tissue to heal. Same thing with diabetes. It takes longer. A scratch may take me 7 days to heal. Somebody with diabetes may take them 2 weeks. So it changes.
What I'm hearing, though, is if I can think of people that would elect to go home when they really should be in a controlled environment.
Nobody really wants to go to rehab.
No,
and we do have cases where people have refused to come to rehab. They go home, and 2 days later they come to rehab because it takes, they have to have that experience that oh yeah, this is not really working for me, and the family. They're too much for the family to take care of. Sometimes the home cares will call us and say, this person really needs to be in rehab.
And generally speaking, most of your patients are 65 or older, aren't they? Generally speaking?
Not necessarily.
No, I was going to say, we've had a lot of younger people in for rehab, 20s on up. It really, we offer so many different types of services that there's a lot of people in the community that can use our rehabilitation.
And I think you mentioned it earlier, but we're just about out of time, but, we've got 1 minute left. How's this paid for?
Medicare reimbursement for those that are over 65 that are not working, that do have Medicare. Medicare would be their primary insurance. And the way that Medicare pays is for the first 20 days, Medicare pays 100%. On the 21st day, Medicare goes down to paying 80%. And up to 100 days, that is the amount that...
That's Medicare.
Mm-hmm.
Okay.
If you have a co-insurance along with Medicare, generally, when you hit that 21st day, your co-insurance is going to pick up the additional 20%. Okay. So if you have a co-insurance, you're golden. You're pretty good. If you're under 65 and you don't have Medicare, insurance pays for it.
Or private pay.
Right, or private pay.
We're out of time, and I want to thank you both for being here today, because I've learned. So if I've learned, I hope our viewers have learned also. But thank you for being here, and I want to thank you, viewer, for watching today's episode of Focus on Seniors. If you have questions or comments, please call radio station WMEL AM 1300 at 321-631-1300. For more information on senior care and resources, visit our website, helpingseniorsofbrevard.com. Thank you for watching, and look at another episode on our demand channel. Thank you very much.